A very good morning to everyone. We're going to move on to our next session on kidney cancer. This is a very super exciting topic. So can I welcome everyone who is waiting outside to come in and join the meeting? And welcome to all those joining us on this plenary session on renal cancer. We have a very exciting topic for you, ranging from focal therapy to surgery. And we're going, and during the discussion, we will be looking forward to all the questions that come through the app so that we can address them. So I'd like to introduce our first speaker on focal therapy for kidney cancer. What's the latest? And really, I think we are all, although we are urologists, we are surgeons, we want to all do surgery, but it is very exciting to have Dr. Cho Wei to give us some insight into what are the alternatives that we can provide our patients. And he is an interventional radiologist with an interest in interventional oncology, and is currently the deputy head of the Department of Vascular and Interventional Radiology and the director of interventional radiology operations at SGH. So we welcome him to give us this talk.
Thank you very much for the kind introduction. We'll start today. So I think the focus for today's talk, we're going to talk about whether if renal ablation is ready for prime time, and these are my disclosures. Now we're going to talk about the efficacy, some of the indications on when to offer ablation, when to biopsy, which I think sometimes is a good question to ask, as well as several others. Now really the type of modalities that we use to treat renal cancers percutaneously is really about a song of fire and ice, isn't it? For heat, you have radiofrequency ablation, as well as microwave ablation. The difference is actually not that stark. They are both needles, roughly the same sizes these days. With microwave, we are getting higher temperature, it burns faster, which is probably why they're getting more in fashion. For cold, it is cryoablation, whereby, again, we put in needles to put ice into the lesion. You're going to start hearing about a little bit more about irreversible electroporation, whether it's in the kidney space or in the prostate space, actually. But this is really under trials and investigation at the moment. It's a very finicky procedure. Everything must be parallel. As I always tell, joke, when I do an IRE for the pancreas, I give my OS to the patient at the end of the day. Now, really, this is a comparison chart about different modalities, and you can see that at the end of the day, the heat, the RFA and the microwave are going to be more available because we are more familiar with them. For cryo, the setup is going to be more expensive, more difficult. Microwave being faster, it burns faster as well, which is particularly why I like them. The cost, cryo is always going to be more expensive. You're going to need argon tanks at the back. The good thing about cryo that we like is that it's predictable. You can see ice ball. Heat is a bit more difficult to see. And the other thing about cryo in the kidney is that there is some data for urothelial injury, which I'm going to show later. Because you're going to use more probes per lesion for cryo, it is also going to be more expensive. For pain, ice is definitely going to be the least painful amongst them. But if the patient's under GA, then this is really not a problem. The reason why cryo is quite popular in the kidney is because there are some papers, animal trials, may I add, is that the normal urothelium actually heals better after ice, and hence reducing the injury, the leaks post-cryoablation. I have to preface to say that, again, this is really with regards to the renal pelvis and the calyces. If you're going to freeze the ureter, it is going to stricture and leak as well, which is why we prefer cryo for lesions that are nearer the central lesions, regions of the kidney nearer the collecting system. Now, this is the indication. I apologize for the busy slide. This is from CERSE, our own IR indications. So CERSE positions ablations as patients who are unwilling or unable to undergo nephrectomy for whatever reason. And it's really at the end again, patients with poor post-morbids, poor renal functions that are really going to be the ideal candidate here. So this is a little video of what we do for cryoablation. So we do most of these in a hybrid CT angio room. This is Michael marking out the trajectory after we have chosen. This is an interesting case. So this is a recurrent lesion post-ablation. You see the little dot there. This is what has been called as a recurrence by radiologists. Because it's going to be quite small and we don't want to mark around. The first thing we do is actually we bring the patient into angio and we stain that area. We stain the little dot with the pie-doll so that on the next day it comes out as, you know, a bright bubble so that we can target it a little bit better. So when we have this lesion, and this currently measures about just 1 centimeter, we target it with one ice, if I'm wrong, ice pearl at the end of the day, and then we do the ablation. At this point, the patient is anesthetized. We put the patient the same side up just to get a little bit more angle. As you can see, the colon is just in front, but this distance is usually quite okay for us. So probably there's no need for additional hydrodissection. This is Dr. Mark Wang performing the procedure. So this is really what you see with the ice rod. You really see ice at the end of the day, and this is quite small size. So we test these at the beginning so that it shows that it doesn't bubble and leak at the end of the day. Sorry. So again, oops, not playing very well. Okay, this is supposed to show the ice ball, but it's not playing well, but it's okay. So we do form the ice ball and the patient was treated well. Now, we have to preface to say that at the end of the day, there is still no good randomized control trial, whether it is partial nephrectomy, radical nephrectomy versus ablation. So we are basing all our talks on retrospective studies or population studies. You're going to see variations of this theme, ablation. You're going to see higher recurrent rates, although almost always the same 5-year survival. You're going to see shorter hospital stay and a better preservation of renal function. Nephrectomy, less recurrence, more impact on renal function. So we're going to go through a few papers. This is one of the latest systemic analysis. As you can see, when you combine T1A and T1B, partial nephrectomy definitely has better recurrence rate. In this paper, there is no significant difference between ablation and partial nephrectomy for T1A. Cancer mortality rates are comparable, and hence this paper then says that percutaneous ablation seems to be reasonable options for patients with comorbids for T1A patients. This is a large CS study. This is one of those American studies whereby they mine the American Medicaid data, and it also shows that there's no significant difference in OS as well as cancer-specific survival between cryoablation, thermal ablation, as well as other nephrectomy groups. So this is something to think about. So which lesions are better for ablation? So there are various nephrectomy scores. Most are probably familiar to surgeons. Some are unique to us. You know, all these numbers and things. So for example, in the renal score, what we always are a bit more fretful of, other than the very central lesions, are the ones in the lower pole, medial, near the ureters. That's normally where you're close to other organs, whereby we do more hydrodissection to get the ureter out. This paper shows that you have a renal nephrectomy score more than 8, a better prediction of complications. Other scores, one of Padua scores that while the scores didn't do very well, the maximum size really predicts local recurrence here. For ablation, more scores, again, really talking about size, central lesions, as well as other structures, giving us a little bit higher complications rate. So in my views, I think size is important. Retroperitoneal structures like the colon and the duodenum can be pushed away. We'll see some later. When it comes to the liver and the diaphragm, I must admit, I don't try too hard. It may be a bit hard to push out the liver sometimes. I'm very respectful of the ureter. This is one thing that gives you endless and ceaseless problems. Again, the difficult locations for us is lower pole, medial location, where it's near the ureter, and exophatic upper pole, and that's because the lungs get into the way, although we can position the patient, as well as central lesions. So this is something that we all like to do. This is posterior, a good size, exophatic, far away from everything. You know, we freeze it, you can see the ice ball, and then after that, then this patient has a growth. So this is one of those lesions that we like. So this is when it starts getting a bit hairy. This patient already has one kidney taken out on the left side, very central lesion. sent to me. So with this, I do tell the patient, I'm so sorry, I may tip you into dialysis if I'm really unlucky. 3 needles into the central lesion, and this patient did quite well. And we did an ablation for this patient. You can see it on the first slide. You can see that this is the post. We can see that the lesion is almost gone, isn't it? Okay. This one, another very central lesion extending to the exophytic region. So we take advantage of the long axis of the lesion by sticking all our needles through. You can see that we have give some contrast with normal saline to push the colon away anteriorly so that we are a bit more safe. You can throw all sorts of imaging. So for these lesions, sometimes we go on CEUS to see whether we have got a good ablation zone to not see enhancement. So thermal insulation for lesions that are very near the duodenum. So while on the supine, you can see that the right RCC is quite far from everything, but when we turn the patient around, everything gets pressed, and you're really near the duodenum at this point. And you can give copious amounts of fluid just to push things away. So that is okay as well. Normally, I just hook it up to a flush bag. So when water doesn't work, we can give gas. You can see we give gas, and it highlights the retroperitoneum. And when none of these work, as we struggle with this case, we managed to put a needle between the ureter and the kidney, inflate a balloon, and to proceed with a fairly aggressive ablation for this patient. A lot of people ask whether cystic lesions are amenable to ablation. I think the short answer is yes, although there's not much literature. Certainly, we have done quite a couple of these. Whether use cryo or microwave, I think it is okay. What about T1B? We're starting to see data coming out for T1B for patients who are not eligible for surgery, coming for ablation. This is not that new, actually, but it does shows that T1B for ablation, while it is not as good for radical nephrectomy, it is quite the same for partial nephrectomy. But again, this is a discussion that's really only for patients that are not eligible for surgery. This is a good question, when to biopsy. So there's only really one paper on this, so that it shows renal biopsy, whether you do it before and you get a good answer before you bring the patient to ablation, or you do just before the ablation and risk ablating a benign lesion. So in this retrospective study, it shows that in a separate session for biopsy, you get a higher diagnostic result, 98.6 versus 84.3. So for this paper, the authors concluded that you should do a biopsy before renal ablation. I tried this with our local patients. Unless we do not offer ablation without a biopsy, not very popular amongst our local patients, I must admit. And also, I think sometimes we must also see the imaging that's available to us before the treatment. Certainly in Singapore and SGH, we throw MRI, CUS, quite liberally to the patient, and we find that our own rates are probably close. Well, it's not 98; it's probably 90%, a bit higher. So, post-procedural, what to expect for the patient? Most patient gets a bit of ache, bruising. Most patients go home the next day. Certainly, they are out and about and having meals when the GA wears off. I really only image after 3 months. Sometimes, if they are older or their renal function is not so good, I can push it after 6 months. Really. Complications, as you can see again, sorry for the busy slide. The complications really, again, falls on the tumor size as well as the location. Again, the larger they are, and the more central the location, and that's where we get more complications. But really, you are looking at the complications rates of looking like this, whereby most are 1, 2, 3, and they're mainly hemorrhagic as well as vascular in nature. Especially for cryo, we are a little bit more wary. Simply because for cryo, you're not burning the thing, so the vessels still can be patent after the eyes have thawed, actually. Again, odds ratio for complication, the usual age, tumor size, central location, as well as the more number of probes you stick in, the more complications you're going to get. Again, this is the follow-up. So normally for cross-sectional imaging, I take them to 5 years, and after that, we will just do an ultrasound surveillance. For those with poor renal functions, we even go ultrasound a little bit earlier as well. Something that I do want the floor to consider, if you have a patient with known VHL, maybe do send them for ablations a little bit earlier. It is not easy to work with I have one patient coming about, about 4 or 5 tumors in one kidney when the patient already has a nephrectomy in the other. And that's when the consent-taking process becomes a little bit more hazardous. And certainly there are some retrospective studies with regards to this. So these are 17 patients who underwent multiple image-guided ablations for RCCs because they have VHL. The results are quite good, and you're losing about 8 mils per minute per BSA for patients with VHL that you send for ablation. So really, when it comes to multiple tumors or these patients with VHL, I do think that we should consider ablation a bit earlier. So inclusion, I think definitely for T1A disease, I think percutaneous ablation is oncologically similar compared to surgery, and it should be offered to patients as a choice, especially if they have comorbid or VHL. We are looking at less renal tissue loss, shorter length of stay. And at the end of the day, for us, technically, thermal insulation is key. Thank you very much.
Thank you, Dr. Tu, for that very comprehensive run-through on the percutaneous ablation. Can I ask if there are any questions from the floor or on the live Q&A chat? Otherwise, I've got a ton of questions. If not, I'll fire first, but do feel free to ask questions, raise your hands, and we'll get to you. So my first question is, in terms of the different modalities and for urologists, counseling a patient to be sent to you, what would you like us to tell them? Because we can tell them on these quite a few modalities. How would we counsel them before?
So it depends on where you are. I think in SGH, we are lucky enough to have clinics. So the urologists say going for ablation, and then we then look at the lesion and tell them whether it's heat or ice. But certainly something that is more peripheral and exophytic, I think generally we will use heat. And something that's more central, we will use ice. Although it is very, very physician dependent at times.
So, and the reason for that is
for the urothelial injury, really. Yeah.
And ice is kinder than heat.
Right, yes.
All right, okay. And, there's a question.
Yes. Can I just ask you, between cryo and heat modality, which one is more susceptible to the heat sink effect?
Definitely cryo is going to be more susceptible, which is why for cryo, for the per centimeter of lesion, we need to use more probes. And that bumps up the expense a lot, as well as the procedural time.
And the second thing is, of course, if you do it under CT guidance, we know that cytotoxicity occurs at -20. And, like using ultrasound, you can't really see -20. You can see a frontier. You can see a CT change when it's 0. So how certain are you that you're actually getting definite cytotoxicity?
No, which is why, we have to freeze larger. So we normally take the edge of the ice ball at 0, right? And there is fairly good animal data to show that you need to be at least 0.5 bigger than the lesion. There is also a question of, on the cryoablation, is the quality of the ice. So in a lot of the machines, they will give you a percentage, you're getting 100% and the maximum intensity 50. So you should really be operating around 70% at least to get a good quality ice ball. And with regards to ultrasound, so I've done a couple of ultrasound for MSK elsewhere. And when you look at the ice on ultrasound, you can see that if you're using a 50% intensity, the ice ball is very irregular. Whereas you're using 100%, you get a very nice edge. And this is some way that we can tell. So generally, for me, we are going for cure. We are looking at, unless in a very location critical place, 100%, 70% to get the good ice quality in the ice.
Great talk, Chow Wei. Thanks for coming. I've got a question on perfusion. So can you share more insights on when and which patients selection will be selected for? Obviously, this will be central tumors, but perhaps more on the protocol, or is there what's the evidence for that?
Yeah,
the outcomes of that.
Thank you. So definitely very central lesions, we will ask the urologist to put a ureteric catheter for us. And depending on the schedule of the day, we can do it in the morning before or when the patient is under GA. And then we will, during the procedure, then we'll start infusing not a lot, a very low volume of warm saline into the T9 catheter to warm the thing, and we just leave it till after the procedure when the patient can pee to take out along with the Foley's catheter. I think this has really been very useful, and this is particularly when you think that ice ball is going to stretch to, if both sides of the pelvic calyceal system, and that's when we are worried that after that, when the thing heals, it sticks together. And I think that's so. Not only we just touch one side a little bit, we may not really bother. But when I know that I need to cross both sides, anterior posterior of the pelvic calyceal system, that's when we really ask for parallel perfusion. Thanks.
One more question from me. Can I ask, for those of us who have to continue our follow-up of patients after the therapy, what are the radiological features that maybe a red flag that would suggest a recurrence? Of course, we will go back to discuss with our MDTs meetings, but what would be the things that we would look out for?
So it's really a hyper-enhancing lesion, which is why we suggest that for both for post-ablation, if you're doing a CT scan or MRI, you really need to include arterial phase. There has been times whereby we won't be seen on just the venous phase alone. So do get a good arterial phase for your patient. We do know that some of the granulation process can take place 3 to 6 months. So if I see, a local occurrence a bit too early, I will probably ignore it first. And even then, they grow slowly. Sometimes we can wait as well. But it's definitely focal enhancing lesions are what we are worried about. Size-wise, really, after about a year or two, they may not continue to shrink very much. So normally, we are looking at the CT scan, the enhancement. Do get the arterial phase. I think that's very helpful.
Okay. Thank you very much. Any other questions? If not, let's thank Dr. Tu.
Thank you very much. Thank you.
Henry will host the next session.
Why not? Good morning, everyone. So we're moving along the line of kidney tumors. We're next going to be hearing from Dr. Prof. Daniel Moon on the boundaries, pushing the boundaries for partial. Interesting to note from the start of this introduction, he's introduced as the urologist who has done the most partial robotic surgery per year in any urologist in Victoria. But more importantly, he's also the clinical associate professor at the University of Melbourne and also involved in the establishment in the training through the Australian Medical Robotic Academy to train the generations of urologists and surgeons for robotic surgery. So, Daniel, thanks so much for your time. Appreciate it.
Thanks very much. Wonderful to be back here again. And I'd like to just go over our journey through partial nephrectomy in Australia. We first performed the first series of partial nephrectomies in Victoria in 2010 is when we established the partial nephrectomy program at Peter MacCallum Cancer Centre and published the first series in Australia a few years later, just demonstrating the early experience and technique and the early adoption and the impressive results even early on which we could achieve using minimally invasive surgery on a robotic platform. A few years after that, we then published the comparison between techniques, comparing it with the gold standard of open partial nephrectomy and showing a clear advantage. And not only was the robotic approach superior, but in the comparison between the robotic and the open procedures were predominantly lower complex tumours, yet they were higher bleeding complications, higher positive margin rates, whereas robotics, in the first 100, 200 cases, we were already tackling larger tumours, more central tumours, and still achieving better results. But as time goes by, you do attempt more and more difficult situations. And what is it that pushes us to the limit? Well, we know there's a number of things that makes renal surgery difficult and can make us uncomfortable as surgeons and increase the operative risk. The patient may have characteristics such as obesity or other body habitus issues that can make access problematic. The tumour itself, whether it's solid or cystic, makes a difference. The tumour size, location is summarised in nephrometry scores, which are widely used, and most often the renal or the Padua scores. And finally, tumour stage, and of course the experience of the surgeon. It's very important to recognise that. And along those lines, it's important to also bear in mind that the only real randomised trial to compare outcomes and survival advantage between radical nephrectomy and partial nephrectomy did not show any advantage in favour of partial nephrectomy. It was somewhat controversial, the findings, and certainly unexpected. But nevertheless, you don't ever want to feel that we need to push ourselves or our patients beyond the limit of what is sensible. And so I always bear that in mind. There's a judgment that you need to make when attempting difficult partial nephrectomies and think, is this really in the interest of the patient, and would they be that much worse off if we do a safer and more simpler radical nephrectomy? So I just preface the talk with that. However, there are cases in which we really have no choice. Imperative versus elective indications, we put together a series based on a database of a number of international centres that we've pulled our data. Since commencing partial nephrectomy over a decade ago, we have a number of centres around Asia, Europe and North America that we put all our data together, and we looked at the use of the robot when partial nephrectomy was for an imperative indication, so renal impairment, solitary kidney, bilateral tumours, and could show again robotics had a very big role to play and could get good outcomes equivalent to those with more elective indications. And these are the sort of situations where we really often have no choice. This is a man who presented with polycythemia and was referred from a haematologist, and he had bilateral large papillary renal cell carcinoma with a paraneoplastic syndrome. And so these could be attempted starting with the more polar tumour, which was the one on the left side. And although it's large, I mean, it's large and it's central, but at least it's at one end of the kidney. So these are a little simpler, even despite the size, but because it is papillary, it's important to, it's not completely solid, there's a cystic component to it, and you have to be careful manoeuvring it, particularly using the robotics without the haptic feedback, and you're often unaware of the retraction pressure that we put on these tumours. You don't want it to rupture. But nevertheless, you could see we could get a good clearance of this tumour down to the collecting system and reconstruct it in the usual fashion. This one is more complicated. This patient was in his 20s and presented with hematuria and had no idea that he had von Hippel-Lindau syndrome until that point. And this was his CT scan. So to be confronted with that as a young 23-year-old was a pretty daunting proposition. And what are we going to do with these tumours? I mean, he's basically was going from urologist to urologist being told that he would need a bilateral nephrectomy and dialysis. So I'll show you the left tumour we did first. So you can see it's quite a large, this one here, a large mass taking most of that upper pole of the kidney. And these are tough because there is no normal plane around this kidney. It's polycystic, so there is a thick rind of cysts and gerotis, perinephric fascia around the kidney. So it has to be mobilised almost in a radical nephrectomy plane, just leaving what we can, and then use an ultrasound to guide where we think the tumour stops and starts, because we have no way really of seeing. But once you've put the ultrasound on, obviously we can see this is all tumour. And then the normal kidney's here, so we can see above that line, that's the resection point. So once the artery is clamped, we follow that carefully scored margin. I've taken it down to the kidney parenchyma, which we see for the first time there now. And starting with the margin, very quickly appreciate the bulk of this tumour. As we come down centrally, that's one of the upper pole calyces. There's a large segmental artery supplying the upper pole that we found clipped and divided. And then quite a large major calyx here, with which he presented with hematuria. There was tumour thrombus there was clot within this, and so you can see the tumour bulging into the collecting system at that point. And coming through the back of that calyx, that could then be our landmark as to where the back of the tumour continued, and I just followed that, and that's another fairly major component of the collecting system with tumour again bulging into it there. And once this comes out, it leaves obviously a very large defect to close, but the principles are pretty much always the same with robotic surgery: minimise the ischemia time. And you can see the key here is to have good ischemia, otherwise this would be, it would bleed heavily and we would see nothing, and it would be a lot more hazardous. So it's very important to follow the usual steps, get good hemostasis, good vascular control, understand your roadmap. And then here it's just a fairly lengthy and careful reconstruction to oversew the vessels, the collecting system, and then bring it all together. And thankfully, although it's a large defect, it's a wedge-shaped defect that we can then bring and actually it came together quite well, and he recovered well. The other side was also performed as a partial nephrectomy, and so that was done successfully. There's a lot of times there is segmental vein involvement with these tumours, and that often may not be appreciated but before the surgery. But you can come across this, for example, and again with the vision and the access of robotic surgery, this sort of finding you can readily appreciate and make sure you still achieve good clearance. So as I come around what is a mid-zone tumour, we see this little tumour thrombus, a snake of tumour extending down a segmental vein. So that can be removed en bloc with the tumour, and that was, gosh, 8 or 9 years ago for that patient, and he's never had a recurrence. So even with the tumour thrombus in that sort of level, early venous involvement, it can be resected. Cystic tumours also pose a challenge because we worry about how we handle them and worry about finding margins. You can't easily lean and retract, and so tumours like this become a little more difficult. This is one that's quite exophytic though, so that makes it a little easier, but you can't sit on the capsule of the cyst as easily as you can with a solid tumour, obviously, because you will potentially rupture it. So you do have to come off the tumour somewhat, although here we can find a little bit of the capsule. I did a bit of it off clamp, but then here I'm coming off that cystic lesion and then just gradually and carefully working my way around it. We can see the cyst as we come deeper, it's bulging centrally into that collecting system there, but with good ischemia and the vision we have, you can also appreciate that we have a good clearance and the cyst is removed completely and without rupturing the component. This one is a little harder. So what happens if you have a completely endophytic lesion like this that we can't even appreciate that much from the outside, and also it's very irregular, so there's no good deep margin. These are trickier, and so I approached this transperitoneally and rotated the kidney over, but again, using the ultrasound, you can appreciate what a complex multilocular lesion it is, and I have to trace out on the surface of the kidney the resection margins. But here it's not, I have to spend a lot of time doing this actually just to, because the last thing I wanted to do early in the resection is cut into the middle of this cystic tumour, potentially contaminate the field, but also then lose where it stops and starts and potentially leave some of the tumour behind. So here again we map it out, and again go on clamp. I just clamped the artery. It's pretty uncommon to have to clamp the artery and the vein, and then this one I have to resect with a wider margin because I just, for the reasons I've said, with a cystic tumour I can't appreciate the bulk of it so easily, and I just don't want to run the risk of entering it. Even though as we get deeper, because this did extend deeply, as I open the collecting system, you can see this cystic tumour bulging in. So, I mean, you've got to make sure your pathologist doesn't call that a positive margin. There is no other margin to take around there. That's the head of it growing into a calyx. So it's still been completely resected. And this proceeded uneventfully. It was a fairly standard reconstruction. And this was a cystic renal cell carcinoma, completely resected in a young patient. What about the more central tumours? Well, I discussed this the other day, and I'll just briefly go over again. This is a paper that Ken Chen put together and has been presented in a few forums and published in the Urology Video Journal, and it demonstrates our approach to central masses, identifying key steps starting with preoperative imaging, the right access, preparation of the hilum, how we expose the tumour, the form of resection, and then a tailored reconstruction. So I won't go through all of these, but this is what I demonstrated the other day. For these sort of larger and central tumours, it's very important to dissect out the hilum carefully, and when we do the resection, like I showed with a cystic lesion, we can't go much deeper than the actual pseudocapsule of the tumour itself when you're on sinus fat. So you have to appreciate that and do a form of what we call a enucleo resection. So you do start off a few millimetres off the tumour, but then very rapidly get a deeper resection. This is a more complex patient. This is a solitary kidney. So again, it's an imperative indication. This patient I actually put in a vascular catheter in preparation for hemofiltration preoperatively, just in case, because I really wasn't sure whether this was going to be successful or not. So he was counselled for a nephrectomy and dialysis, but with the sort of vision we get with robotics, again, there has never been such an ideal platform for renal surgery. These are complex cases, but what you need in these cases is the best possible vision, the best access, the best manoeuvrability, and the robotics provides all that. And so that could be resected. He maintained his renal function and had a clearance of that tumour. Reconstructing these, as I said the other day, is tricky because we can't close the kidney properly. So we have to avoid oversewing deep vessels that are uninvolved. We have to avoid dividing them in the resection to start with. And we do it in 3 layers, starting with an individual ligation using fluoroviral, just running around and oversewing deep vessels in the base of the tumour, followed by an underrunning of the corticomedullary junction using a 3O monocrystal, just to capture the arcuate vessels. That's where a lot of the secondary bleeds or AV fistulas can also come from. And then finally, a bolster sutured in to stop the cortical ooze and prevent any smaller hematoma developing. And that's been very effective in all cases. We've not had any bleeding post-operatively from these cases. While I'm talking about nephrectomy, I would also, the first layer of just a fluoroviral individual ligation, that is the layer that prevents you having secondary bleeds. So secondary bleeds are not a complication that you should accept happens in 5% of the time, which I saw in my first 50-odd cases. And it became quite clear that it is a failure to individually close those deep vessels. If you just do a mass closure, then those vessels are captured in the mass closure and can open up again, and that's where you get your secondary bleeds and AV fistulas and pseudoaneurysms that bleed later on. If you pay attention, take time to oversew those individually, that complication won't happen. So consider that a technical aspect that you can minimise the risk. What about fat patients? These are hard. And these sort of things, this is not captured in nephrometry scores. This patient here has what is quite an easy tumour on a nephrometry score, but this is one of the hardest cases I've ever done. What you can see is all this edematous, toxic retroperitoneal fat around this kidney that made the access and the approach so horrendously difficult. There was a layer of fat on top of a layer of fat. Before I got to the toxic fat around the kidney, that's Gerota's fascia with an inch of fat reflected off, and I still have another layer of toxic fat. I got completely disoriented. I was scrabbling around looking for the psoas muscle here, just trying to retract the bulk of this big kidney mass. And as I'm scrabbling around looking for the psoas muscle, I found the renal vein, which was unexpected, but thankfully it allowed me to find the hilum, get a little more oriented. But these could be dangerous. They can be very difficult. It's easy to get lost. You have to keep reassessing where your landmarks are. And then when you get to the tumour, you have to get ultrasound again. This tumour is not difficult, but I cannot get down to it off clamp so easily because it's just in this thick concrete layer of fat. And so once we're on clamp, you have to cut through that again just before I find the kidney parenchyma. I think I'm just starting to find a bit of kidney there, and then it can be resected. These are tough, and it's usually males, and you can predict it by that streaky edematous change in the retroperitoneum that you can see on the preoperative imaging. And they're also the ones that you should really avoid a retroperitoneal approach because they're a nightmare. Prior surgery, just quickly, well, you should always have a retroperitoneal approach up your sleeve because this does give you an added option for patients that have posterior tumours or they've had a lot of abdominal surgery. I touched on this the other day, but it's a really nice technique to be able to make a space behind the kidney, lift it forward, find the hilum, and then you have a workspace that avoids the peritoneal cavity at all. So, and I showed this the other day. This is a similar one that was performed for a solitary kidney, retroperitoneally, Gerota's fascia incised, hilum dissected, and I was able to perform it off clamp. So in conclusion, we've come a long way with robotics and are still really learning and developing techniques, but there has never been a platform like this as good for complex renal surgery. It really does allow you to offer nephron sparing through a minimally invasive approach, even in quite difficult situations, but it still requires very careful selection, and your approach needs to be tailored to the individual situation. And finally, we still need your experienced surgical team, but good judgment so that we're tackling the right cases by the right people to ensure that we have success and minimise our complications. Thank you.
Thanks, Daniel. Any questions from the floor? Yes, Dr. Loh.
Yeah, great talk. Just asking you on tips, really. Those toxic perinephric fat, and certainly those that peel the capsule off with it. Any tips? That's actually the toughest part of
They are the toughest.
many of these operations.
It makes or breaks you. That makes or breaks you. You would much rather do a difficult tumour in a thin patient than a simple tumour in that sort of patient. It's a nightmare. There is no simple solution except you just have to sculpt the fat off the kidney. If you need to avoid also, as you say, if you get too close to the kidney and are really pedantic about getting all the fat off, you may just strip the capsule off the kidney and then you haven't got anything to hold your sutures. So if in doubt, I'll leave a little bit of the fat and use your ultrasound so that you can still get that compromise between seeing what you need to but not damaging the kidney. You just have to take your time. And with partial nephrectomies, the more mobilisation, the better. One of the traps when you first start, if you don't mobilise enough, you'll find that suddenly you can't reach as well. You always get bleeding in the place you can't reach or can't see well. So always have it more mobilised than you think. If you're doing upper pole tumour, the first thing I mobilise is the lower pole. So you can flip everything and make sure you get all the angles that you need to resect and to sculpt and to sew. So all I can suggest is have a very good assistant, have a good sleep the night before, and just take your time.
Nathan, yeah.
Dan, fantastic talk. Just wondering about the role of ureteric stenting, either temporary or a double J. I certainly had a difficult case about 6 months ago, and he presented with a urinoma about 3 weeks post-surgery with a very long reconstruction of the collecting system. And I've had a couple since that have been tricky, and I've actually just put a double J stent in,
Yep.
which doesn't take much time. So do you think there's any role for either a temporary ureteric catheter or a double J stent in some of these cases?
A double J stent's not a bad idea. I haven't done it, and I haven't been caught out yet. I'm sure my time will come. The trap with the ureteric stents, because I've seen people like to put those in, you keep squirting and you'll always find a leak. If you put enough pressure, it's super physiological. So as you close the collecting system, squirt the catheter, and you'll see more fluid come out, and you just stress yourself that you haven't closed it properly. So I'm not sure about a catheter, but if you have good hemostasis and you do, again, the quality of your resection makes the reconstruction. So if you have a good quality resection, you'll see through the planes where the collecting system needs to be closed. And I will close that separately. No mass closures. Take your time to use a 4 Vicryl. I do the vessels, and I also separate sutures, close that collecting system like you would close a pyeloplasty, or make sure it is watertight as you can before you then do a mass closure and then put the cortex on top. And I haven't had trouble. But I guess maybe the bigger case, the VHL sort of case, we could have put a double J stent in. That's the only thing perhaps to be very conservative.
Thanks. Just waiting in for any live question or anybody from an audience. I do use the ureteric stent tube chance to check whether there's any defect for some of the very difficult partials that we do. Since you're very experienced between lab and the robotic surgery, maybe for cases where there are access to robotic systems, where do you feel the boundary might look like for someone who may not have the robot access?
I started off doing laparoscopic partials, and what I was able to achieve with the robot was chalk and cheese. So you can still do simpler tumours laparoscopically. I even did some more complex tumours, but you can't get as good a resection and as good an ease of reconstruction. So I just think it's all heading robotic. One of the other things you can do also are some hybrid approaches. So, for example, there are cases where we've had multiple tumours and the ischemic time you think may be a little long. And so you can dock the robot or laparoscopically, dissect the kidney, mobilise everything, loop the vessels, and then make a little flank incision, bring it up, and everything's already mobilised, and do sort of a hybrid open and minimally invasive procedure. So you can also marry the techniques a little as well.
Okay, good. Any other questions from the floor? Yep.
To flip the questions around, is there any case of partial nephrectomy you would do open?
Oh yeah. A lot of multiple tumours. At this stage, probably redo renal surgery. Still, some of those I think you may prefer to do open. The other trick that I've had though for redos, I would say, when the vessel loops in the von Hippel-Lindau cases that I've done, when I sling the vessels, I leave the vessel loops there. And they're inert, They stay there. The companies don't like it. The nurses don't like it because their count doesn't match. But you can come back years later and the vessels are already slung. So that helps for cases with multiple tumour syndromes where you're likely to be back there. Why not make life easy for yourself the next time?
Maybe for next week, as everybody go back to work and they see the next tumor and decide to push the boundaries for themselves, and they were given the choice of choose 3 scenarios: endophytic tumors, cystic tumors, and at the same time a large, very hilar tumor. Which one would you think in sequence would be somebody would choose to start with?
I think you look at the nephrometry scores. A small endophytic tumour, we did those quite early. A small lip of sinus tumour, they're not that deep actually. They can be done well. A cystic tumour that's not completely endophytic, it's good to get practice in handling. So it comes down to size and depth. Any of those situations, if it's not too big and it's not too deep, that's what I'd be starting with. And then you start tackling the deeper ones. And it took me a while before I was comfortable doing solitary kidneys robotically. That was the other situation where I would have a low threshold to do it open. Because then you can use ice, you can cool.
Great. Thanks, Daniel. Thank you. Thanks so much. Thank you. Next, we have next section will be moderated by Melvin.
So, we never used to get radiation oncology presence in RCC, so it's a good, gives me great pleasure to welcome my dear colleague and friend, Associate Professor Shankar Siva, who I think is delivering the lecture virtually. So Shankar is a radiation oncologist and the current Cancer Council Victoria Kobach Fellow at the Peter Mac Cancer Center. He leads the SBRT program at Peter Mac and is internationally recognized in this form of precision radiotherapy delivery. He is also acknowledged as the first academic that published the original research from Australia on the use of SABR technique. And I think Shankar leads several clinical trials in the genitourinary cancer space. He's currently the chair of 5 trans-Tasman radiation oncology group, the TROC group studies in lung, prostate, and kidney cancers. And he's also the chair of several committees from the American Society of Radiation Oncology, as well as the European Society for Radiotherapy, SBRT, Asia. So I think it gives me great pleasure to have Shankar speak to us today on the role of radiation therapy in the management of RCC.
Hello, my name is Shankar Siva. I'm a radiation oncologist at the Peter MacCallum Cancer Centre. My talk for you today at the UROFAIR is Rethinking Radiation Treatment for Renal Cell Carcinoma. I'd like to thank the organising committee for the opportunity to speak to you. Renal cell carcinoma is historically considered a radio-resistant type of tumour, and this has been found even in the early days of radiotherapy with this analysis published in 1985 of patients treated between 1956 and 1981 for palliation with renal cell carcinoma. Doses range from 20 gray to 60 gray, and the authors found that the time dose fraction equivalent required to get a reasonable response of 65% was actually quite high at above 70 gray. However, the idea that renal cell carcinoma is radio-resistant has been ingrained in the literature for the longest time, and certainly I've learned about it in my radiation oncology training textbooks. It may be, however, that the idea of radio-resistance is specific to the use of conventional radiotherapy. This is a cell survival assay with dose in radiation on the x-axis and on the y-axis a logarithmic scale for cell survival. And in the 2 most common human cell renal cell carcinoma cell lines, the A498 and the CARCI1 cell lines, we can see at doses of 2 gray or less, there's only a small fraction of cell kill that is noted. And this is a shoulder in the cell survival curve. However, at doses of 6 gray and above, this is represented by logarithmic types of cell kill. And it may be that high doses per fraction are able to overcome this inherent radioresistance. We do know also that there are different mechanisms of cell kill using high-dose radiation therapy. And this is a paper from Nature Reviews Oncology that we published, indicating that high doses of ablative radiation have alternative therapeutic effects, including endothelial apoptosis, ceramide or sphingomyelinase-induced cell death, and pro-inflammatory signaling that can actually induce adaptive immunity and adaptive responses with CD8 positive T cells. Our group actually performed a meta-analysis of the literature looking at patients that had received stereotactic ablative radiotherapy for oligometastatic renal cell carcinoma. And in this study, published in European Urology, we identified 1,600 mutually exclusive patients with 680 extracranial patients and 920 intracranial patients, and almost 4,000 lesions having been irradiated. The intracranial local control rate with this type of approach using stereotactic radiation is quite high at 90% at 1 year. And this is similar as well in the extracranial literature with a pooled local control rate of approximately 90%. SABRE for oligometastatic RCC is now guideline recommended, and this is in the NCCN Guidelines 2022, which indicates that metastasectomy or stereotactic radiotherapy can be used as ablative approaches for oligometastatic disease for both clear cell and non-clear cell histology. This paper was recently published, which is looking at the use of stereotactic radiotherapy in a prospective phase 2 trial in lieu of systemic therapy in patients with low volume metastatic disease. This study out of MD Anderson enrolled 30 patients with a median follow-up of 17.5 months, low volume of metastasis at a median of 1 metastasis, and the 1 year progression-free survival was 64%, and the median progression-free survival of 22.7 months. This resulted in the primary outcome being the 1 year freedom from systemic therapy being 82% in this cohort. So certainly did delay the use of systemic therapy in this group. There is also the consideration of using SABRE not to delay or in lieu of systemic therapy, but to be an adjunct to systemic therapy. And this is a study in the oligoprogressive era, which is in patients who are receiving a TKI therapy. And in this study, patients who are progressing in limited sites of disease, up to 1 to 3 sites of oligoprogression, were then enrolled and delivered ablative doses of radiation. The authors from Sunnybrook reported that the 1 year local control rate was 93%, and the median progression-free survival after stereotactic radiotherapy was 9.3 months. And remember that these were patients already progressing on their TKI, and this approach of local ablative therapy was able to extend this progression-free survival for a further 9 months. With this strategy, the median time to switching to systemic therapy, which is otherwise becoming ineffective, was 12.6 months. In the modern era, we're becoming more cognizant that SABRE actually is immunogenic with the use of immunotherapy, and there may be some unique synergies with these combinations. We know that radiation has multiple effects, including direct cellular damage to the tumor, releasing tumor-associated antigens into the tumor microenvironment. This can result in dendritic cell activation and proliferation, and upregulation of major histocompatibility group protein 1, which allows cross-presentation of these antigens to the adaptive immune cell compartments. This eventually results in a anti-tumor priming effect with activated CD8 positive T cells, and radiation in itself can actually result in cytokine release, which can allow for homing of these activated anti-tumor CD8 positive T cells back in the tumor microenvironment to allow and enable cell kill. This is an example of a patient who did actually receive SABRE and anti-PD-1 immunotherapy, and I've put this figure up here of interest because this is a patient who had a sarcomatoid variant of renal cell carcinoma with clear cell predominant histology. This patient relapsed with oligorecurrent disease, one with a right lung with a sarcomatoid biopsy-confirmed component, and one in the renal bed with a clear cell component. And interestingly, the functional imaging characteristics are quite different. The lung is very FDG avid with a sarcomatoid component, and the renal bed is very PSMA avid with the clear cell component. With the use of SABR and anti-PD-1, we see dramatic responses in relation to the SABR. This was a single fraction of 20 gray of SABR, and this resulted in a dramatic tumor regression at this site of disease. We typically don't see such vigorous responses to SABR. We often take very many months to actually observe tumor shrinkage, but in this combination with the SABR and immunotherapy, we certainly saw some synergistic regression of disease. So this is an example case when we may be interested in the use of SABR and immunotherapy. This is a patient, a 62-year-old with an ECOG performance status of 0, who is a full-time manual labourer. The patient had a pathological T3B, N0, M0, clear cell renal cell carcinoma of the left kidney, which was resected with an 85 millimetre tumour in January 2015. The patient then had a synchronous right lung metastasis resected, and 2 further lung metastases developed shortly afterwards in September 2015. This patient subsequently received SABR to 2 of these lung metastases in the left lung in October 2015. And on surveillance, afterwards in 2016, in April, there was some subtle increased uptake within a left bulky adrenal metastasis on an FDG PET scan performed at the time. This was low FDG uptake, and this was biopsy confirmed as an isolated metastasis in this site. However, the PSMA avidity definitely did show that this was very active, indicating the clear cell component of this particular adrenal metastasis. This patient then had a synchronous This patient had low FDG uptake within this adrenal metastasis, and therefore we confirmed the imaging by using a second functional imaging with PSMA PET. Given the clear cell component on the PSMA PET, this light lit up very actively, but more importantly excluded other occult metastatic disease. So looking at the tempo of this patient, he had the primary tumor resected in January 2015, a synchronous right lung metastasis resected at that time, and 2 further lung metastases treated with SABR in October 2015. This April 2016 left adrenal metastasis was then presented, and we thought that this is still reasonable to consider a metastatic ablation approach. This patient had a 40 millimeter RCC in this side, in the left adrenal metastasis, and these are serial PET scans on PSMA, showing the development of the PSMA PET avid disease in the middle panel, and after adrenal SABR on the right panel, a complete functional response. However, 6 months after adrenal SABR, this patient then developed new lung metastasis. One was a scar recurrence within the previously resected area. Another one was a new lung metastatic disease. So at this stage, in October 2016, there was new right lung metastasis, and the question must be asked, is more local therapy futile? Was the tempo of disease too dramatic? So overall, this patient actually had metastasis-directed therapy for 6 different treatments, with SABR for 5 sites of disease and a metastasectomy for a synchronous lung metastasis. The systemic therapy was delayed from the time of initial metastatic disease by more than 3 years, and the patient eventually went on to having immunotherapy after having SABR to multiple sites of disease. The idea of synergy with SABR and immunotherapy was delivered in this recent publication in the EAU in April of this year, which is for the Rapport clinical trial, and this is in European urology. And this study was a study that was conducted at Peter Mac and at the Princess Alexandra hospitals in Australia. The population were patients with up to 2 lines of prior systemic therapy and up to 5 sites of oligometastatic disease from clear cell renal cell carcinoma. The intervention in question was 20 gray of SABR in a single fraction, or 30 gray in 10 fractions of conventional radiotherapy if not feasible, to all sites of metastatic disease followed by pembrolizumab 3 weekly for 8 cycles. The comparator, this was a single-arm study, so the historical comparator of Keynote 427, the pembrolizumab alone was used, and the outcome was safety and efficacy as the primary outcomes. We recruited 30 patients in total, and there were 83 sites of oligometastatic disease that were irradiated. So an average of 3 per patient, often more than what's reported in the oligometastatic literature. The majority of patients received SABR, with 64 lesions receiving SABR, but 19 or 23% received the conventional radiotherapy. The predominant pattern of disease was in lung metastasis, with 43 metastases to the lung, but then lymph node and adrenal and bone were also closely followed. The average age was 62, and most patients did not receive any prior systemic therapy, although some patients had metastasectomy, approximately a third, and about 23% had a TKI or interleukin-2 therapy prior. The median follow-up in this cohort was 2.3 years, so quite significant, and the disease control rate in this group was 83%, which is defined as complete response, partial response, or stable disease for a period of greater than 6 months. This is a waterfall plot describing the responses in patients in a per patient series in the middle in purple, and on the right, that's per lesion, and looking at both the orange being lesions that receive SABR and blue being lesions that receive conventional radiotherapy. These are dramatic waterfall plots showing quite a dramatic response, and this is certainly not just the immunotherapy alone. It's definitely the combination of radiation and immunotherapy, because we don't see these type of responses with systemic therapy alone. The best objective response rate was 63%. We found that the median progression-free survival was 15.6 months, and the median overall survival and median duration of response was not reached. The freedom from local progression with this type of treatment at 2 years was 92%, showing that this synergy was effective both locally and distantly for controlling disease in this patient cohort. So from the report trial, the takeaway is that the combination of SABR and short-course pembrolizumab in oligometastatic renal cell carcinoma was well tolerated. The rates of grade 3 toxicity were 5%, with excellent local control. The observed progression-free survival was at 15.6 months. The objective response rate of 63% compares very favorably to a pembrolizumab monotherapy comparator, with Keynote 427 showing progression-free survival of approximately half at 7.1 months, and objective response rates of 34%, again similarly close to half. Therefore, the durable responses and encouraging PFS that we observed in this cohort definitely do warrant further investigation in further larger trials. So I think for us, we can safely say that radiotherapy for oligometastatic renal cell carcinoma, specifically SABR, is ready for prime time. We can describe now confidently that renal cell carcinoma is not radioresistant to ablative radiation, and prospective trials with SABR alone, oligoprogression and oligoprogressive disease, and a new frontier with SABR and IO in metastatic disease. We now have 3 prospective trials in this setting, which all show very much benefit. So SABR for oligometastatic RCC is guideline recommended, and I would consider no longer experimental. I'd like to thank you very much for your attention, and thank you again for the invitation to speak to you today. Thank you.
Oh, great. So you're here, Shankar. So great talk. Any questions on the floor? Yep, go ahead, Danny.
Hi, Shankar. Daniel Moon here. How are you? Great talk. I just had a question about the very impressive series, of course, and you know I've enjoyed working with you with a lot of these patients, and a lot of the patients that we look at doing non-surgical treatments on have a lot of other comorbidities, particularly say anticoagulants, and therefore it may even be risky taking them off anticoagulants for procedures at times. In that sort of setting, are there situations where you would treat without doing a biopsy, or are you always very much biopsy driven to know the histology of the tumour before offering SABR?
I think it depends on the context too. For oligometastatic disease, where we're confident, where often these patients might have had a previous metastasectomy, then I don't think we need biopsy confirmation, or if it's clearly metastatic on radiological features. In the primary setting, I think it might be a little bit different. If you asked me 5 years ago, I would have said we just didn't have enough information. It's too new a treatment not to have a biopsy confirmation. But now I think I'm a bit more comfortable if the patient has serial imaging features that are showing enlarging primary renal mass, for example, with classic radiological features. I think we can consider it, but typically my preference is biopsy first.
On that point, now I saw that in a few of the cases you had both FDG PET and PSMA PET imaging. Could you comment on that? Because in Singapore context, I mean, PSMA PET is way more expensive than FDG PET.
Yes, absolutely. So that's the equivalent of what we call an Easter egg. You plant something in the talk and hope someone asks the question. So yes, PSMA PET is very useful in this kind of context, particularly for clear cell renal cell carcinoma. PSMA PET binds to the neovasculature in the tumor, and renal cell carcinomas, as we know, are very vascular tumors. We find this particularly useful in the context of oligometastatic disease that we might be screening for local approaches, whether that be metastasectomy or SABR, because this can potentially reveal other areas of occult metastatic disease and prevent futile therapy. FDG PET is quite useful for highly aggressive and metabolically active, fast-growing tumors. PSMA PET tends to be really useful, particularly in clear cell renal cell carcinoma. And to be honest, it's my preferred way of screening and staging if you have access to both. But I do understand it's a limited evidence field, and accessibility and expense is a consideration.
Questions? Any other questions on the floor? Yep, go ahead.
Good morning. Often these patients may be renal functionally compromised, with one kidney already removed and a met appearing in the contralateral kidney. I may have missed your detailed discussion on the nephrotoxicity to the remaining glomeruli.
Question. I mean, I think this relates to, because I think just asking about radiation to the kidney itself.
Yeah. And that's a very good question. We have looked at this in detail both at Peter Mac and with an international organisation called IROF, which is a pooled group of institutions. Largely speaking, nephrotoxicity is actually quite modest. It seems to be the equivalent of what we can see with partial nephrectomy. On average, with dual kidneys, we tend to see in the longer term a rough loss in EGFR around about 7 mils at 2 years. And in the solitary kidney, it seems to be consistent too. I think the difference within the medically inoperable patient with dual kidneys is that they tend to have a lot more other comorbidities that lead to eventual chronic kidney disease anyway. They often have diabetes, often have hypertension, many other issues. The patients that I tend to see from a solitary kidney after having a prior nephrectomy, for example, they tend to be younger and fitter and have less medical comorbidities. In fact, they tend to hold their EGFR quite well. So on average, it's about 10% loss, about 7 mils per minute at 2 years. And there's several publications we've listed. You can find them at European Urology and Cancer and Journal of Urology.
So I think in the interest of time, I mean, thank you again, Shankar, for the great talk, appearing again for the Q&A, and look forward to seeing you soon. All right, thank you. By Henry again.
Hey, great. So next we have an old friend, Prof. Ong Teng Ek, the topic on the cytoreductive nephrectomies, new rules of engagement. So we all know that Prof. Ong is currently the president of the MUA, the Malaysian Urological Association, and the head of Department of Surgery in Faculty of Medicine in Malaya University in Kuala Lumpur. So maybe we'll have him to come on top to give the talk on the cytoreductive nephrectomy, new rules of engagement. Thank you.
Hello, thank you very much for the opportunity to speak in UROFAIR 2022. I am Dr. Teng Ek Ong, the current president of the Malaysian Urological Association. So I hope one day I could be there in person in Singapore to join all of you. Yeah, I love to travel to Singapore. So the topic for today is cytoreductive nephrectomy, the new rules of engagement. This is a very relevant topic to our everyday practice. Acknowledgement. I'd like to thank you again. Yeah, these are the picture that I would like to see in person. Yeah, very soon, hopefully. Do you do cytoreductive nephrectomy? This is a question often asked, but of course, it's not a straightforward yes or no. It all depends. It all depends. There are many factors that we need to consider. Yeah, before we embark on cytoreductive nephrectomy. So I will give you a case example of a patient we saw more than years ago in early 2021 during the peak of the COVID-19 pandemic. We have this 54 years old, very young man who came with gross hematuria, who actually didn't smoke and had no other risk factor. The CT scan show a horrendous tumor, from the right kidney invading into the inferior vena cava, and also metastasized to the tail of the pancreas. So here we have a metastatic RCC, which was confirmed by a biopsy. So what do we do now? So the question is, will our team do a cytoreductive nephrectomy? So yes or no, or depends. Yep. So of course we have that MDT in our team. Most people who present the case in such a prestigious conference will say, yeah, we did that. We are hero. Just like Tom Cruise. But however, we have decided not to proceed with the operation of upfront cytoreductive nephrectomy. So we are sort of like top chicken instead of top gun. We have in the MDT have decided to start the patient off on systemic therapy. So of course there are arguments for cytoreductive nephrectomy upfront in terms of palliating the symptom, enhancing immune response, delay the disease progression, and might improve survival as we see in the retrospective data, and you get the whole histology to study. The arguments against, of which we will often take those into considerations, are the morbidity of the operation. Of course, the level 1 evidence are only with interferon therapy and reduced quality of life. Because they might have post-op complication, have to have prolonged stay in the hospital, and the disease might progress after surgery, and the patient have no chance of getting systemic therapy. That's something we do not want to happen. In the cytokine era, interferon, the benefits are proven. So we have all these randomized control trial showing the survival curve that we were very familiar with. Okay, so the conclusion during those era of interferon, it shows better survival with cytoreductive nephrectomy. But however, the rate of cytoreductive nephrectomy had declined over the years throughout the world. I think we still see this trend. Then, more than 10 years ago, we moved into the targeted therapy era. The benefit is questionable. Of course, the result from retrospective series, they were very encouraging with huge number. However, as we can see here, only certain groups of patients derive benefit from upfront cytoreductive nephrectomy. For example, those with younger age with better performance score. And if you look down closer on your right-hand side, even those with better insurance coverage might derive benefit. Yeah. So here again, in the targeted therapy era, we have two very well-known randomized controlled trial that we often quote in exam and in daily life practice, the Camina trial and also the Certain trial, trying to study the role of cytoreductive nephrectomy. So the outcome from Camina, of course, we know that both the treatment arm, there are significant patients who did not have the per protocol treatment, and also the patient population are just mainly intermediate or poor risk patients. That's for the Camina, and these are the survival curve that we get for overall survival and progression-free survival. And the study showed that there was no difference in response rates in term, and also the progression-free survival as well. That is for Camina of sunitinib plus cytoreductive nephrectomy versus sunitinib alone. So the conclusion was that sunitinib alone was not inferior to nephrectomy, followed by sunitinib in patients with metastatic RCC, who were in the intermediate or poor risk group. Okay, of course, we know about the limitation of such studies. And then come Certain. This was the study design of Certain, and the patient population only managed to recruit 99 patients. And we have the survival data here on progression-free survival and also overall survival. So in terms of the progression-free survival, it was obvious from the curve that there was no significant difference here between the two curves. They all somehow married and merged together. And we do see some separation for the overall survival curve. That the median overall survival was significantly better of 32 months for patients who have deferred cytoreductive nephrectomy compared to 15 months for those with upfront cytoreductive nephrectomy. These were the secondary endpoints. Okay, so in conclusion, from a Certain, defer cytoreductive nephrectomy did not improve the 28 weeks progression-free survival. However, with the defer approach, more patients could receive sunitinib, and the overall survival result appear to be higher. So that is something that we should take into consideration. So it is, to us, kind of pre-treatment with sunitinib, we'll be able to select, to identify patients, who are, actually, resistant to systemic therapy. So it will be, we call that a good test. So of course, there were numerous shortcomings of the Certain trial as well, including the small sample size. So the interpretation need to be taken with caution. Then, from targeted therapy nowadays, in the past few years, it's all about immunotherapy, focusing on immune checkpoint inhibitor, IO plus TKI, IO plus IO, and so on. So we are bombarded with numerous encouraging results from the trial, of which many of these drugs are already in the guideline and has become the standard of care. So we don't have much data for patients who are receiving immune checkpoint inhibitor in terms of cytoreductive nephrectomy. Of course, there are kind of retrospective observational analysis. For example, this was an analysis on cytoreductive nephrectomy for metastatic RCC treated with immune checkpoint inhibitor or targeted therapy. So here, with the observational study, it appears that there is a role for cytoreductive nephrectomy, with immune checkpoint inhibition and also with targeted therapy as well. So the lower diagram also show the beneficial effect in terms of overall survival, with ICI and TT. So the summary from such an analysis will conclude that there might be a role of cytoreductive in the era of immune checkpoint inhibitor. Of course, these are observational data with its own selection bias. So are there any level 1 evidence available? In this, nowadays there are 3 randomized controlled trial being conducted now. You will see that often being quoted. The PROP study, using EP and Nivo, and another study, Nordic Sun as well. The agent is EP Nivo, and study the role of cytoreductive nephrectomy. And the third one will be Cyto KIK study. The agent used cabozantinib and nivolumab. So hopefully we get more information in the future on the role of cytoreductive nephrectomy using various combination of IO plus TKI, IO plus IO. This will be very exciting. So back to the patient, that we did not operate upon. So this was the original CT images. The patient received Nivo plus cabozantinib for a year with very good response. As you can see here, the primary tumor has shrunken significantly together with the IVC tumor thrombus. However, the pancreatic metastatic lesion remained the same size. So this is consistent with the data from the numerous immune checkpoint inhibitor trial showing very encouraging kind of response, ORR, for such therapy combination. I think roughly 50% or more of patients would have some form of response. So this happened to this patient, and we proceeded with a right nephrectomy and IVC tumor thrombectomy and the distal pancreatectomy to remove the metastatic lesion. So we became the proud chicken at the end. So this is a very nice diagram that summarizes the current approaches to the patient with metastatic RCC in terms of the role of cytoreductive nephrectomy. Immediate upfront cytonephrectomy will be applicable for local symptom control for patients who do not need immediate kind of systemic therapy, or patient with who are very good performance status and also have only perhaps one IMDC risk factor. So this patient will benefit from upfront cytoreductive nephrectomy. And for the case illustrated just now, he have more than 2 IMDC risk factor in the intermediate risk. So he had systemic therapy first and had deferred cytoreductive nephrectomy. So that is the patient being illustrated. I would think that the approach of deferred cytoreductive nephrectomy have a big role to play in the era of immune checkpoint inhibitors. So the fact and kind of recommendation illustrated earlier in my talk are reflected in the current EAU guideline, which emphasize that we do not perform cytoreductive nephrectomy for patients with poor risk. And of course, for selected patients with intermediate risk, there was a role for cytoreductive nephrectomy. So in summary, the rule of engagement now, cytoreductive nephrectomy is not the standard of care for all patients. So that's not so straightforward. So it might have a role for selected group of patients, as I have mentioned earlier. Deferred cytoreductive nephrectomy has a role, especially for patients who have some form of response to systemic therapy. And of course, we await for more data from the ICI trial. Of course, we will work closely with our friend, the oncologist, to work together in the MDT setting to chart the best course for our patient. So with that, I'd like to thank everybody, and a special thanks to Kenneth Chang of SGH for introducing me to the conference, and also to Kanesh and Ong, who helped me to fact check the presentation as well. Both are senior specialists from my team. And I hope, despite the jam in the causeway, I will be able to visit Singapore in the very near future. So thank you very much, and we should proceed to the Q&A and discussion session. I would love to hear from everyone on your comment on cytoreductive nephrectomy. So thank you very much.
Thank you. Thanks. So, good morning. Can you hear us well?
I can hear you well. Hi, good to see you online.
Great. So, any questions from the audience? Also, there's live Q&A. Please feel free to fill in the questions. Kick off by asking, with all this in mind, any tips and tricks for someone who's thinking of the level or boundaries of difficulty for cytoreductive nephrectomy? Any thoughts on where someone should stop thinking about it and decide to go ahead? Any anatomical advice for all of us here, especially the time where everybody tries to be maverick, and sometimes, in fact, the rooster do survive the second Top Gun show instead of goose. So, any thoughts on this one? Yeah.
My thought is, I think everybody got different. I call that comfort level on how far to push ahead. Depend on the urologist, and also the multiple team involvement, vascular surgery, hepatobiliary surgeon, and even cardiothoracic surgeon. It depends on the comfort level. Yeah, some team are comfortable to push ahead with very advanced cases. Some will be more conservative. I think there's no fixed rule to that. And nowadays, of course, with patient with intermediate risk or high risk risk group, if this kind of systemic therapy is available and patient is suitable, I would actually prefer to go ahead with systemic therapy first. How about your approach in Singapore General Hospital? Daniel, hi Daniel.
Daniel, to answer the question, there's a question to answer.
Maybe we let Daniel comment.
Daniel Moon from Melbourne. That was a fabulous overview. I really enjoyed that. I was wondering if you could comment on your experience performing deferred cytoreductive nephrectomy after systemic therapy. Do you find that the downstaging may make your operation easier, or does the tumour effect from the systemic therapy make the operation more difficult?
Thanks, Daniel. I think this is a relevant question. Yeah, we give immunotherapy. It kind of induce a systemic inflammatory reaction to attack the tumor. So always the worry is that will that inflammatory change make the operation more difficult? I think there's no straightforward answer to that. I think it differs from patient to patient. For the case example that I've quoted in the talk just now, the operation was somehow straightforward. So we were lucky. But if you read on the literature, on certain report from some other center on such kind of delayed cytoreductive nephrectomy, they do face a lot of challenges for some patients because of local tissue reaction, and sometimes the blood loss could be significant. One study I read, the average blood loss was almost 1 liter for such a patient. So we do have to be very careful on that. So the local tissue reaction, the difficulty of the operation do varies from patient to patient. If you get lucky, it could be very easy, and some cases could be quite sticky. Yeah,
I think the presence of a vena caval tumor thrombus influence your decision? Are you happy still to defer a cytoreductive nephrectomy if there's a large tumor thrombus within the vena cava?
Yes. So if there's a large vena cava tumor, am I comfortable to defer cytoreductive nephrectomy? For me, I will of course bring it to the MDT for discussion, and I'm actually comfortable to delay cytoreductive nephrectomy for selected patients. So if there's a role and a patient is suitable for systemic therapy, that could be an option to kind of downsize the tumor and making subsequent operation easier and perhaps safer.
Nathan?
Yeah, hi, Nathan Lawrenchuk, also from Melbourne.
Hi, Nathan.
Hi there, how are you? Great talk. Look,
Hi.
when I did my fellowship in Toronto, over 10 years ago, it was pretty straightforward. It was if there was more cancer in the kidney than elsewhere, you did the nephrectomy, and if there was more burden outside, you would sort of push them towards systemic therapies. And I know studies have cleared that up, and you've made that clear today. I still find paraneoplastic syndromes very interesting, and we've all seen patients where we take out the kidney and almost within 24 hours, the paraneoplastic syndromes resolve. The dilemma we have is often we have these patients presented at the MDT where they've clearly got a paraneoplastic syndrome. I'm not talking about recurrent hematuria or even pain. Obviously, that would be indications to do it, but they've got these significant paraneoplastic syndromes, and the balance is there. You've got a moderate burden of disease outside the kidney and so on. I still struggle to see the data that putting them onto systemic therapies gets rid of that paraneoplastic syndrome, although some people say yes, some people say no. And I often wonder if we're not doing a favour to our patients by not proceeding to nephrectomy, as long as it's a doable nephrectomy, of course, and safe. What is your view on that, the patient with the paraneoplastic syndrome?
Yeah. Hi, Nathan. Thanks for the question. So I think for the patient with paraneoplastic syndrome, I think that there's one factor that probably will kind of push us towards earlier, perhaps upfront cytoreductive nephrectomy, if that's at all possible. So that will kind of we will settle the complication and the problem related to the paraneoplastic syndrome. So so specifically for such a patient, I would probably advocate for upfront nephrectomy, upfront nephrectomy, if that is at all possible, before systemic therapy. So Nathan, I think you make a good point there.
Maybe while we still have taking it online, I just want to get maybe Tanuja to comment on the role of this particular situation where paraneoplastic and the role of immunotherapy. Yeah, thanks.
Thanks for the question, Henry. So to be very honest, I haven't seen that many paraneoplastic syndromes in our situation. And I think, as Nathan mentioned, there isn't very much data to go with it. But I think it really depends on what paraneoplastic syndrome you're talking about. If you really cannot control this and you feel that going ahead with the nephrectomy is the way to go, then yes, if it's possible to even do this cytoreductive nephrectomy. But otherwise, I think looking at the data, and being a medical oncologist myself, I probably will go for the systemic therapy first, because with the data there is a possibility that with systemic therapy your paraneoplastic syndromes can get better as well.
Great, thanks. Thanks, Teng Ek. Once again, before this become another MDT, we will move on to the next speaker, and I'll leave it to Johan to present it. Thank you. Thanks, Teng Ek. Catch you around. Thank you.
Bye.
Bye-bye.
Thank you. Bye.
Hi, everybody. So I'm Johan. I'm the moderator for today. Today we have a colleague of mine, Dr. Tanuja. She's a medical oncologist as well, and then working in the National Cancer Center. She's also the medical director of Changi. The topic today will be on optimal approach to systemic options in high-risk localized RCC and metastatic RCC. Dr. Tanuja.
Thanks very much, Johan, for the introduction, and thank you very much for the invitation to speak here. It's always a pleasure to speak at the UROFAIR. And so my talk today is titled Optimal Approach to Systemic Options in High-Risk Localized and Metastatic RCC. These are my disclosures. So this is a very, very, very big topic, and so I am going to focus on metastatic RCC. If we have time, I would cover the adjuvant treatment. Otherwise, at tonight's dinner symposium, this topic is going to be covered. So I'll start with the data first. What do we know so far? And then we'll talk about how can we individualize therapy in the first-line metastatic RCC setting and what we can expect in the future. And as mentioned, if we have time, we'll cover the adjuvant treatment for high-risk localized RCC. And I'm happy to take any questions at the end. So this is always very exciting as a medical oncologist to share this slide, because this slide shows how metastatic RCC has evolved and continues to evolve. So if you look at this timeline prior to 2005, all we had was cytokine therapy, which was high-dose interferon, IL-2. Responses were not great, toxicities were high, and essentially we didn't have. It was not a good treatment option. And then come 2005 onwards, we had a slew of VEGF TKIs. They were oral drugs, fairly well tolerated, but really we weren't curing our patients. And then came 2018, and then we had the immune checkpoint inhibitors, and since then we really have had a treatment revolution. And if you are a medical oncologist treating metastatic RCC, it is really a happy situation to be in, and I'll be covering the data of immune checkpoint inhibitors. So this table shows the top-line data for the first-line immune checkpoint inhibitor trials in metastatic RCC. I have left out the Javelin trial because that didn't show any overall survival benefit. I'll be going through these studies in a bit. So I'll start off with the Checkmate 214 study. This is the first immune checkpoint inhibitor study that was published in 2018. Essentially included patients who had treatment-naive, clear cell metastatic RCC, and they were randomized to either the standard arm of sunitinib versus the experimental arm of a combination of nivolumab and ipilimumab, which is a CTLA-4 inhibitor, followed by maintenance nivolumab. And the primary endpoint was PFS, OS, and overall response rate in the intermediate and poor risk population. And this is the study with the longest follow-up. And if you look at the overall survival, at a median follow-up of 48 months, the overall survival benefit for the combination arm is 48 months versus that of 26 months in the sunitinib population. Let me remind you, this is the intermediate and poor risk metastatic RCC. So here we are saying that patients are living to a median of at least 4 years. So this was previously unheard of. And if you look at the progression-free survival benefit with the combination arm, the median PFS is about 11.2 months versus 8.3 months with the sunitinib arm. But what you do notice, if you look at from the 2-year mark onwards, you see that a tail is appearing in the combination arm. And this actually means you have patients who have completed the initial induction with the nivolumab and ipilimumab. They are just on maintenance nivolumab, and they are actually progression-free for the next 36 months, 48 months. So patients are really doing much better now. And in terms of response rate, overall response with the combination is about 40% versus that of about 26% with sunitinib. And if you look at the complete response rates, it is about 10% with the combination versus you hardly see any complete responses with sunitinib. And if these complete responses are durable, essentially you have a 10% chance of curing your metastatic RCC patients. And again, these are intermediate and poor risk patients. I will bring you to the column on the left, looking at favorable risk. What is interesting to note is that in the favorable risk population, the sunitinib arm had an improved response rates compared to the nivolumab and ipilimumab arm. And in terms of adverse events, most of the adverse events with the combination arm is grade 1 and 2, and most of them tend to occur in the first 6 months. Yeah. Okay, so what is interesting to note is that if you have patients who have discontinued the immune checkpoint inhibitors due to treatment-related adverse events, they still seem to derive benefit. If you look at the curves there, compared to patients who have discontinued secondary to some other reason other than treatment-related adverse events. Okay, so I move on to the next study, which is the Keynote 426 study, which looks at the combination of immune checkpoint inhibitor plus VEGF TKI. Again, very similar inclusion criteria, but this study included patients from all risk categories. So favorable, poor risk, and intermediate risk. Patients were randomized to either a combination of pembrolizumab plus axitinib versus standard of care arm, which was sunitinib. And looking at just the median follow-up at 12.8 months, the primary endpoints of OS, PFS, and overall response rates were all statistically significant. If you look at the overall survival here, the curves separate very nicely. The combination arm shows the overall survival benefit. The median is not reached versus the median overall survival of 35 months with the sunitinib arm. Similarly, in terms of response rates, the response rates with the combination arm is about 60% versus that of 40% in the sunitinib arm, and CR rates at about 8%. You do note that the response rates and the progression-free survival for the sunitinib arm in this study is better than the previous study, and that is because there was a higher risk of favorable risk population in this study compared to the earlier Checkmate study. Moving on to the Checkmate 9ER study, I think this was mentioned by Prof. Ong earlier. So patients, against very similar inclusion criteria, all metastatic RCC, treatment naive, clear cell, all IMDC risk groups, they were randomized to either nivolumab plus cabozantinib versus sunitinib. Primary endpoint was progression-free survival, and the PFS was statistically significant, median PFS of 16.6 months for the combination arm versus 8.3 months with sunitinib, and the overall survival curve separating very nicely, median not reached for the combination arm. And in terms of response rates, very similar to the pembrolizumab study, 55% with the combination arm versus 27% with the sunitinib arm, and CR rates for the combination arm about 8%. Okay, this study had another interesting metric, which was the health-related quality of life. You know, patients are living much longer, so quality of life becomes a very important consideration. And you can see that using the FKSI index, patients preferred the combination arm compared to sunitinib. And the last study that I'm going to discuss is the CLEAR study. Again, similar inclusion criteria, but this study had 3 arms, the control arm being sunitinib and the 2 experimental arm being first one being the combination of pembrolizumab plus lenvatinib, second one being a combination of lenvatinib plus everolimus. It is important to note that both this experimental arm was compared against sunitinib and not against each other. Primary endpoint was progression-free survival, and if you look at the progression-free survival curves, both the combination arms did better in terms of progression-free survival compared to sunitinib. In terms of overall survival, only the combination arm with pembrolizumab had a statistically significant overall survival benefit over sunitinib. Okay, in terms of response rates, this study is very impressive because you look at the overall response was 72% in the combination of lenvatinib plus pembrolizumab versus that about 29% in the sunitinib arm, and the complete response rates in this study was 14% compared to that of the control arm. So, you know, if you've just heard me talking about the studies, if you're a non-oncologist, you're like, hey, everything sounds very similar. Overall survival is positive. There are PFS benefits. So essentially, what do I choose? All of them sound the same. So I don't think we are ever going to have a study that is going to compare all the different regimens against one another. So this is a retrospective study that was published by IMDC, looking at comparing the IO regimen, which was the nivolumab, ipilimumab, versus the IO VEGF TKI combinations. And what they found essentially is that there is no overall survival benefit. So in terms of efficacy, they are generally similar. So then you're going to ask me, how do you decide? Okay, maybe for the urologist, say, thank God, right? I don't have to do this. Let the medical oncologist do this. But so how do you decide? Is it because this company pays you to give talks, or is it just because I wake up this morning, I prefer nivolumab, I'll use that, right? So these are some factors that I consider. So if you have if you have a patient in front of you who is in visceral crisis, you need an urgent response, you need a quick response. Essentially, you want a regimen that can act fast. Essentially, all the combination regimens act fairly fast. The median time to response is about 2.8 months. So definitely, you would choose a combination therapy over single agent VEGF TKIs in this setting. Okay, if you have patients with favorable risk in IMDC classification, what we have seen with the data is that the IO VEGF studies compared to sunitinib have shown that they have better PFS and response rates, but essentially the overall survival is the same. So what do you do? But what we also know from the Checkmate study is that yes, the VEGF TKI has better response and PFS compared to the IO regimen. But if you look at the graph in the middle there, if you have patients, among the patients who do respond to ipilimumab and nivolumab, they tend to have a more durable response. So clearly, there is a subset of favorable risk patients that respond to immune checkpoint inhibitors. And are you able to tell among your favorable risk patient who is going to do better with immune checkpoint inhibitors, who's going to do better with VEGF TKI? Currently, based on the IMDC risk criteria, you can't. But from the Emotion 151 study, we know that clear cell RCC can be divided into various molecular subtypes. And based on those gene signatures, we know that for patients with the androgenic gene signatures, they tend to do better with VEGF TKI. If you have a more proliferative gene signature, then you probably do better with immune checkpoint inhibitors. So if you look at the graph here, if you look at this graph here, what you see that among the favorable risk population, 75% of them have the androgenic gene signature. So about 75% of your patients would probably do well with the VEGF TKIs, but you see there are about 25% of patients who have the proliferative gene signature and may require IO. At this point of time, with the current IMDC criteria, you can't tell which gene signature they belong to. But however, with hopefully some upcoming studies are going to be molecular directed, biomarker directed. So if they have more of an androgenic gene signature, then they are randomized to a IO VEGF TKI. If you have more immune-driven gene signature, then you have the IO combinations. Yeah. So again, patients with a one chance response. So these are patients either visceral crisis, risk of cauda equina, or they are going to have a big mass going to cause a main bronchial obstruction. Essentially, you have no chance for salvage for this patient. You've got a one chance response, whatever one chance of response. Whatever you give them, they must respond, right? If not, then you're going to lose this patient. So in this case, you basically want to choose the regimen that has the lowest PD rates. And if you look at the chart there, essentially you want to go with the IO VEGF TKI combination, because for the IO, the ipi-nivo, the chance of progressive disease as best response is 18%, which is higher than an IO VEGF TKI combination. Okay, and with regards to the sarcomatoid variant, basically you need an immune checkpoint inhibitor combination rather than a single agent VEGF, because if you look at the meta-analysis, the sarcomatoid variants do much better with the IO combination. So, and then the last point I want to talk about is toxicities. If you look at the graph here, so compared, you can see that for the IO regimen, the discontinuation rate due to treatment-related adverse events is about 22% versus that about close to 10% for the IO plus VEGF TKI regimen. And you can see the use of high-dose corticosteroids with this IO regimen is much higher compared to the IO VEGF TKI regimen. So really, you have to have a discussion with your patients. If you go for the IO regimen, there is a 5% risk of major immune checkpoint inhibitor toxicity. What I mean by this is that patients have chance of myocarditis, myasthenia gravis, hepatitis, and there's a 30% chance that this patient may need high dose steroids, and potentially some patients do not even survive this severe IO toxicity. But if this patient survive this IO toxicity and they are potentially off therapy, there's about 20% chance some of these patients with major IO toxicities are off treatment, and then they continue to be off treatment and be progression free. So basically, it's like a big bang, boom, you have a major toxicity, and if they survive that, they tend to do very well even if they are not on treatment. Okay, but on the other hand, with the IO plus VEGF TKI combination, your risk of major IO toxicity, not so high, about 1 to 2%. The patients needing high-dose prednisolone, not so high as well. But you have to deal with the chronic, annoying VEGF-TKI toxicity in the background all the time. So you have to deal with the diarrhea, the mouth ulcers, the hand-foot syndrome, the hypertension, and there's no data on whether you can stop the VEGF-TKI or not. So you really have to have a discussion with the patients and see which one they are okay with, essentially. So how to decide? Essentially at this point of time, basically, if you're in the case of a very aggressive disease, you use a IO-VEGF-TKI combination and you wait for the tail of the effect of immunotherapy. Otherwise, you can head for the long-term benefit of the IO-IO combination. And the question I always get, is there any role for single-agent VEGF-TKI in the current situation? Yes, for certain favorable risk patients with active autoimmune disease where you cannot use your immune checkpoint inhibitors, patients who are frail, patients who prefer oral therapy. Okay, I know my time is up, but I'll just very quickly go through what we can expect in the future in the first-line metastatic RCC. So I think this is probably something that the urologists will be very excited about, and we spoke about this earlier. So we know that with the Camina and CERTIME trials, there was no improved survival with cytoreductive therapy, cytoreductive nephrectomy, and initial systemic therapy followed by nephrectomy has better survival outcomes than upfront nephrectomy. But in the setting of IO-based regimens, the role of nephrectomy has yet to be evaluated. And if you look at the first-line IO trials, you see that 80%, close to about 70 to 80% of patients had nephrectomy in these studies, and you know that the median overall survival is about 48 months with these patients. But if you look at patients who had synchronous metastatic disease but yet did not have nephrectomy, their median OS is only 26 months. Is this something related to the nephrectomy? Don't know. So this is a upcoming trial. So these are patients with synchronous metastatic RCC. They are going to be started on an IO-based regimen, and if they have a partial response or stable disease, they are then randomized to either continue systemic therapy or go for a nephrectomy followed by systemic therapy. So hopefully that will help to answer this question. And the Cosmic 313, very similar to the Checkmate study, but what they're looking at is whether a triplet regimen will do better than just a IO-IO regimen. So this is something that we await in the future. The Pedigree study hopes to answer the question of whether for patients who had upfront nivolumab and ipilimumab, and if they did not progress or did not achieve CR, is there a role for intensification of therapy? So for patients who did not achieve either of these endpoints, they are either cabozantinib is added to nivolumab, or they just continue on nivolumab, and we see which arm does better. Okay, so what to do when patients progress after the first-line treatment? Basically, you use any of the combinations that you haven't used. Lenvatinib, everolimus, cabozantinib, axitinib, whatever you haven't used in upfront, just use it at the next line. Okay, I'll just skip this part and then we'll talk about this tonight at the dinner symposium. So I'll end off by saying PD-1 inhibition is now considered the backbone of frontline metastatic RCC treatment, and there are many considerations to weigh when you are deciding on which combination, and we await more biomarker and molecular work in the first-line metastatic RCC. That's all I have. Thank you very much. Happy to take any questions. Yes.
Thank you. That was probably the best talk I've ever heard from a medical oncologist, so congratulations. Wonderful summary. I just had two questions. My first one is, when you look at all those trials, was sunitinib never tried in combination against those drugs because those drugs on their own were already better than sunitinib, or was it purely because the drug companies were trying to test a new drug? Does that make sense?
So yeah, I understand your question. So that's a fantastic question. It was tested again. Their combination was tried, but the liver toxicities were too high. So they did the combination of the IOs with sunitinib and pazopanib because those were the first two TKIs that we were using, right? But the liver toxicities were too high, so they couldn't do it.
My second question is, we often have these cases that come back to the MDT and they've got, say, lung mets and so on. And you know, our medical oncologists are very good, Ben Tran and Arun Azad. They're all saying, oh, we're looking at the tempo of disease before we start systemic therapy. So my question is do we have a better measure than just sort of the feeling of the tempo of disease and when to start these drugs? My second point is, do they have a finite period? So are we better off delaying them a little bit because we know that the drugs are only going to work for 3, 4, 5, 6 years? Or are we better off starting them earlier in the hope that there'll be a patient who will get a more prolonged response?
I'll tell you, I'll probably be very similar to your medical oncologist. So you see, so that in patients with lung-only mets, they tend to do very well. And because they're not in visceral crisis, there's no rush to treat them. So I have quite a few patients with lung-only metastatic disease. They start off with a little nodule, and then over the next year, they grow a little bit. So I've got some patients who are not on treatment, metastatic RCC with slow-growing lung mets, and they're off treatment for about 5 years. So, and there's actually no data to say that if you start them earlier, they do better. And in fact, in your NCC guidelines, it's been stated that it is very reasonable to watch such patients. So we know that patients who do well are lung-only mets, those with pancreatic-only mets, and essentially, if you look at their molecular classification, they usually have the PBRM1 mutation. But usually, if you just look at a patient, you can't tell. And so, if there is no, if I have a sort of a feel, and I don't know how to describe this, but if they can wait, I would probably say, let's just scan you in another couple of months, 3 months time, and let's see how the metastatic disease does. If it's growing very slowly, let's continue to watch you. And if the patients are in no hurry to get treatment started, I would just continue to watch. But if you have a young patient and you want a potential chance of cure, and if the patient understands the risk of the IO toxicities, then I would start them on an IO a combination regimen, hopefully aiming for the cure. I hope that answers your question.
Sure, thank you.
Hey, Tanuja, very, very good talk. I thought I know this topic well until I listened to you again. So my comment and question is, for the targeted therapy era, we always insist on treating patients with clear cell histology. I mean, it makes sense because all the targeted therapy are anti-VEGFR, the mechanism of actions makes sense, and you'll find this the driver for this would be in clear cell RCC that has racial mutations. I think it makes sense. But in the immunotherapy era, with all these immune checkpoint inhibitors, we are really looking at different mechanisms of action, isn't it? So how relevant it is to still insist on the histology of clear cell RCC. But if you look at all the keynote trial, and the inclusion criteria is clear cell RCC component, I think it has some implications for us to refer to the medical oncologist because you guys always insist on the histology. My question is it time that we treat these patients as all-comer and forget about histology? Because we are using a different type of therapy now. And I mean, along this line, what is your experience in treating patients apart from clear cell RCC with this new type of therapy?
Okay, thanks, John, for the question. So you're right. Non-clear cell RCC is a bit often, right? So you've got about 70% of patients making up the clear cell RCC. The remaining 30 to 25% are non-clear cell RCC, and we know that non-clear cell RCCs, while we tend to throw them into a basket group and say they're all the same, but they are not. So you have the papillary, you have the chromophobe, you have the translocation RCC. But what we do know is that the papillary RCC, they are MET-driven tumors, and that's why we have data for the papillary RCCs that you use a MET targeting agent like cabozantinib, and so there's phase 2 data saying for metastatic papillary RCC we do first line cabozantinib. Okay, and then your question is, of course, why can I just throw an immune checkpoint inhibitor in? But you're right. So for most patients, after, let's say, they progress on, if you're a papillary RCC, if they progress on cabozantinib, we would treat them as if they're a clear cell RCC. And in fact, for all the other subtypes besides the papillary one, the chromophobe and all that, we do treat them very similarly as the clear cell RCC. But in knowing why is it important, knowing whether they are clear cell or non-clear cell for trial options. So their clinical trials would not accept you unless you're clear cell for certain clinical trials, and for the non-clear cell, there are specific trials for those, number one. And number two, for prognostication. We know that non-clear cell RCCs generally don't do as well as your clear cell. But having said that, for most of my in the current situation, for most of the non-clear cell RCCs, we treat them in a very similar situation. And in fact, for my papillary RCCs in some of patients with very high volume disease, I'm very tempted to give the nivolumab cabozantinib combination, right? Because cabozantinib will target the MET part, and if they have an immune component to it, then the immune checkpoint inhibitors would treat that part. Currently, we don't have any large data, but there have been some posters presented on it showing that there is activity with the nivo-cabo combination in the papillary RCC.
So am I right to say if patient decline a biopsy, it wouldn't affect your management?
No, you need
Apart
to.
from that, they can't go on trial.
No. We still need a biopsy because firstly we need to show that this is RCC to begin with, right? Yeah. So, and just by going, I mean, I don't think, because we give such toxic drugs, right, that there's a risk of fatality with these drugs. I know the way I say it is like, so, people can get cured and all that, but we do see patients die from some of these therapies. So if you're going to give someone something, we better make sure we're treating the right thing, because in your kidney tumors, I've seen one, what was supposed to be RCC turned out to be a lymphoma. I mean, most of the time you're right, it is going to be a RCC, but I think we need to be 100% sure here. I don't think we will be defended in court, if you don't have histology. Happy to take any other questions.
If there are no other questions, we might end the session today.
Thank you very much.